Okay, and we are back to discuss diabetes and obesity that have their onset in adulthood. Forgive my computer for being a little bit slow. So, we will talk about the two types of adult onset diabetes, MODY or maturity onset diabetes of the young, and we'll talk a little bit about type 2. Now, type 1 can occur in adulthood, it just more commonly happens in childhood. I have a table that compares the three. The defining characteristic of all types of diabetes is hyperglycemia or elevated blood glucose. In MODY, we usually see it somewhere in early adulthood, before the age of 25, but not typically in childhood. Um, so that's why they call it mature onset. The pattern of inheritance, it is a single gene disorder. It is autosomal dominant, meaning that if you inherit it from one parent, penetrance is about 90%. So you'll usually end up expressing this diabetic trait. Um, 85% of the people that have MODY, there are like actually 14 separate types, six are more common and more commonly tested for. But most people who have MODY have type 3. That describes about 65% of people. And the remaining 20% have types 1 or 2. I'll show you a table on that. But the genes involved play a role either in insulin production, secretion, or glucose metabolism. It sometimes gets misdiagnosed as type 1 or type 2. Often it does. And genetic testing, as that evolves, hopefully we'll be catching more of these cases because the treatment we'll see is a little bit different. If you get a copy of this gene from each parent, both parents have MODY, it is dominant, it will express itself, you will be severely affected. Um, so just a few facts about MODY. Here are all of the genes. Now, blood sugar, metabolism, insulin production, secretion, sensitivity, it's regulated by many different genes. The most common are these 1, 2, and 3. And you see number 3, HNF1 alpha is the most common. And that can lead to impaired beta cell function, just like type 1. So it acts like type 1, but it happens later in life. There are some people with MODY who are older than 25 at diagnosis, but generally you see it in young adulthood. So here's a table that compares. Type 1, majority under the age of 25. The real key is that you end up with these ANA antibodies, okay? So the autoantibodies that attack the pancreas beta cells are present with type 1 diabetes. That's one of the distinguishing features. You see it's absent in both type 2 and MODY, okay? So that would be a way to distinguish that. With type 2 diabetes, typically it's greater than 25, but we're seeing so many kids now with diabetes. Differences: overweight is usually not as big a predictor of MODY as it is for type 2. Type 2, 90% of the people are at least overweight. Whereas in MODY, it's similar to the general population. Insulin dependent. Well, in type 1, yes, absolutely dependent because your beta cells do not make insulin. But in type 2, it's a question of insulin sensitivity, and we'll cover that in a minute. With MODY, no, but they are usually sensitive to sulfonylureas to help them transport that insulin out of the pancreas and into the circulation where it can work. Insulin sensitivity. This is where MODY is different from type 2 diabetes. MODY, you have normal insulin sensitivity. You're not insulin resistant necessarily. Whereas in type 2, you have decreased insulin sensitivity. You are more insulin resistant. Type 1, if you're controlled, you're normal. So these are some of the ways that we could distinguish the different types. And that's important to do because treatment is going to be tailored to whatever's causing. It's going to be more effective if we know what's causing it. So family history in type 1, yes, there is a genetic component. We discussed it in pediatric disorders, but there's also got to be that virus. that triggers that autoimmune response. In type 2 diabetes, very heritable, 75 to 90% can be accounted for with family history. With MODY, you see multi-generational. You can trace your family 2, 3 generations back and see that they have developed this diabetes. Rare to get DKA with either type 2 or MODY. So MODY has similarities with type 1 and differences, and similarities with type 2 and differences. And, the treatment, MODY usually responds well to sulfonylureas. Um, whereas type 2 responds better to metformin, some of the gliptins, things that increase insulin sensitivity. So if you know what that person's genotype is, if you did a panel and you saw that it was in fact MODY, you could treat it more appropriately. Okay, now we're going to talk about diabetes mellitus type 2 and obesity. We call them complex disorders. They are not caused by a single gene. They are caused by interactions between genes and the environment and each other. So they are complex, they are polygenic, and sometimes the etiology is not entirely clear. So we know that there are a large number of genes that control blood sugar metabolism. It's an important function of the body because the brain needs glucose, and so do all the other tissues. So it's sort of each one has a little contribution, and they interact with the environment. So any alteration in this kind of puts you at higher risk. You have enough risk factors, you end up with the disease. So diabetes and obesity are leading causes, along with heart disease, hypertension, of morbidity and mortality. So it's important to understand them. There are a lot of genome-wide association studies being done, not a lot of conclusive evidence to support things like the thrifty genotype, although we know there is a thrifty phenotype. But they are looking, and there's up to maybe 70 genes involved in the development of type 2 diabetes. And it probably takes more than just one or two of them acting with the environment. It probably takes several. So again, we have persistent hyperglycemia, elevated blood sugar. With long-term exposure, anybody with diabetes and hyperglycemia can get microvascular or macrovascular complications. And those would be things like retinopathy, neuropathy, nephropathy. The key characteristic of type 2 diabetes, as opposed to MODY or type 1, is that you have insulin resistance. You make insulin, at least in the beginning of the disease, you can make a lot of insulin. But there's an effect where it's like insulin's like a key that opens the door for glucose to enter the cells. The key doesn't work. The receptor's not responding to insulin signals, and that changes the cell's permeability to glucose. So symptoms might appear gradually where maybe with type 1, you see a more rapid onset. The child will appear very thirsty, very tired, hungry all the time, peeing all the time. Whereas with type 2, it's a little more subtle. So very often what you have is a delay in diagnosis of up to about 7 years. And in the meantime, this person might be getting neuropathy, retinopathy, other complications. Nearly 8 million people in the US population are walking around with blood glucose of 200 or 300, and they don't even know it. It runs in families, a high heritability estimate. It's about 70%-ish. Okay. Not simple Mendelian inheritance, not like sickle cell disease. If your parent is a carrier and your other parent is a carrier, you have a blah, blah, blah chance. About 7% of people nationwide are affected with this disorder. About 30 to 40% of them will have one affected parent, 70% with two affected parents. Identical twins, 60 to 90, not 100, but close. It's about as high as autism or schizophrenia. More younger people are being diagnosed. You're seeing kids being diagnosed in childhood with the increase in childhood obesity, sedentary lifestyle of children. Um, but it does run in families. There is definitely some genetic basis. We just don't know all of it yet. We have identified some genes that are implicated. The idea of a thrifty genotype, that this evolved, people would store sugars and foods as fat, and that fat could create insulin resistance in a famine. Um, it's attractive. They started talking about this back in the 60s, but they've never been able to identify, a candidate gene or, a group of really good genes that prove that theory. What we can see is a thrifty phenotype, and that points more to epigenomics, like that Dutch hunger winter that we talked about, prenatal nutrition, paternal factors, especially like paternal excessive exercise, and then your offspring is sedentary. So there are a lot of things that they're looking at that can contribute to the thrifty phenotype. And the thrifty phenotype is a body that wants to store every calorie as fat and save it for that famine. So anything that could kind of trick the body into that thrifty phenotype by methylating genes, like that agouti gene that we saw, better nutrition, increased normal offspring, even in people who had that agouti, mice that had that agouti phenotype. Risk factors, these are your environmental exposures. There are many. Um, Overweight or obesity being the biggest one, especially if it's abdominal obesity. If you have a waist circumference greater than 35 inches, you are at risk for diabetes. Sedentary lifestyle, big one. If the muscles aren't used to taking up glucose, they become insulin resistant. Smoking increases insulin resistance. Having a baby greater than 9 pounds at birth is a risk factor, probably due to some underlying mechanism that caused both things. The baby didn't cause the diabetes, just it was indicative of some metabolic. Maybe they were never diagnosed with gestational diabetes, but they had some issue with glucose metabolism. And lastly, there's a lot of research into exposures to endocrine disruptors. And I don't see it, it's not on this slide, but there's some research on the microbiome, which I can talk about in a minute. But things like BPA plastics and many, many others have been implicated in the development of insulin resistance, especially chemicals that are stored in body fat. They can alter the way that fat uptakes glucose and also the way other cells do as well. So some candidate genes have been identified, but they don't totally explain the etiology of the disease. So in certain populations, you see a gene called calpain 10, more common in Mexican Americans and people of Central American descent. Um, there's PPAR, which codes for a protein that breaks down fat and keeps body fat cells smaller. That is more common in Caucasians, but many, many people have this gene. And in some countries or some populations, it's up to 98%, and they don't have a 98% diabetes rate. So you can see the problems with identifying the genes involved here. ATP binding cassette. This is a gene that controls the release of insulin and glucagon. That balance in the body, glucagon is made in the liver. And when the body needs more sugar, it will, you have glycogen. Glucagon stimulates the release of glycogen and glucose into the blood. Um, so these are some of the genes they've identified. I don't think you need to really memorize these, but just understand that it's not just one gene, and it probably takes a combination. But we do see it more commonly with certain chromosomal problems. So people who have an extra copy of a chromosome or they're missing one, um, do have problems with diabetes mellitus. So Down syndrome, there must be something on chromosome number 21 that regulates glucose. Prader-Willi is another one. And when you saw the ghost in our genes, there was a little thing about Angelman syndrome versus Prader-Willi. And they showed a little boy who was very, very obese. They have like this excessive hunger, and they have a higher rate of diabetes. Turner syndrome associated with diabetes mellitus. Some of the genes that control weight are on the X chromosome, and that's why you also see it more commonly with Klinefelter. There are some single gene problems like Wolfram syndrome. Be lying if I told you I was super familiar with that. But sometimes when you see a syndrome, a cluster of symptoms caused by some genetic problem, diabetes mellitus will be part of that cluster. So we do know that it's genetic. We just don't know how all of it works yet. Obesity, another condition that is causing a lot of decline in lifespan and quality of life for people, defined as a body mass index greater than 25 or greater than 30 is obesity, 25 is overweight. Genetics accounts for about 40 to 70% of the variation in BMI. You see it in families. Some people run bigger, some people run smaller. Um, some ethnic types tend to be more prone to obesity. And there are some candidate genes that they've looked at in this, and a lot of them have to do with the regulation either of how the body spends its calories, how it absorbs its calories, and appetite. So appetite is governed by hormones like leptin and ghrelin, and an imbalance in those can lead to overeating. Um, and then, all these other genes. But that's, if you remember that the basic pathophysiology, obesity is an illness. It is not a character flaw. It's not a cosmetic issue. It is an illness. And there are many chemicals or components in the human body that regulate energy balance. So any defect on any of them predispose a person. And of course, when you offer foods that are high in calories, and refined and processed, sometimes the body kind of just stores all of that and has a harder time losing it. And we're going to take a break there, and we'll come back and discuss autoimmune disorders.